So we are going to talk about treatment of malaria and also thrombocytopenia. We've already seen that thrombocytopenia commonly occurs in severe forms of malaria, especially those that have P. falciparum and P. vivax. But in most cases, there is no episodes of significant bleeding that occurs with thrombocytopenia that occurs due to malaria. Although in a few instances, it can occur. And from most of the literature that I looked at, there is no robust, clear evidence on how to particularly manage thrombocytopenia in severe malaria. And in most cases, a conservative approach is adopted in the management of thrombocytopenia. So the key aspect of management of thrombocytopenia that is caused by malaria is usually to treat the underlying cause. Several studies have shown that if you treat the malaria, which is causing the thrombocytopenia, the platelet counts usually they improve, they normalize, and within 7 days, most times the platelet counts have normalized. But it can go up to 28 days. And I think as seen from our patient at the time of discharge, I don't know what the platelet counts were. They were still 51. They were still a bit low, but we expect maybe if we did the CBC in 21 days, in 28 days, we expect probably the platelet counts have normalized. Platelet concentration transfusion is only indicated in patients with systemic bleeding. We've seen that DIC can occur with severe malaria. And if they have DIC, then you can consider giving a platelet transfusion, or you can consider other blood products, maybe fresh whole blood, and and then as I was also going through the literature, there was actually really no role for things like corticosteroids, and it's advised to avoid things like NSAIDs, which can worsen bleeding in children who already have thrombocytopenia and severe malaria. So even if they are spiking a fever, you'd probably want to use paracetamol to control the fevers and avoid things like NSAIDs, avoid corticosteroids, and So for the treatment of malaria, of course, you have to treat the severe forms of malaria which is causing the thrombocytopenia, and it's important to look at all the emergency measures which you need to take within the first hour that the child presents to the unit to manage all the complications that are there. You want, if the child is unconscious, you want to look at the ABCD. If you want to check for hypoglycemia and correct it, you want to, if they're having convulsions that are not resolving, you want to manage it accordingly. And like I already said, effective antimalarial treatment is the key in the management. So the antimalarial treatment of choice, it's usually for severe forms of malaria, we want to use parenteral antimalarials, and in our settings, the first line is parenteral artesunate, which is the drug of choice for the treatment of P. falciparum malaria. But if not available, you can still use artemether or quinine. But we've already seen from the previous presenters that quinine can actually cause thrombocytopenia itself, so it's really preferable to use artesunate, IV artesunate. And it's advisable usually to give the IV treatment for a minimum of 24 hours, even if the patient could take orally maybe after your first dose or second dose, but it's advisable you give for a minimum of 24 hours before you change to the oral treatment. And if the patient cannot take orally, then you go on giving the IV treatment for a maximum of 7 days. So that is briefly. The doses, I think we all know them. I don't need to go through them. Thank you.